So I think the concept of identifying somebody at short-term risk is tremendous, and I think it's very worthwhile. We'll have to see how successful we are at being able to identify those patients who are going to have an event in the next month, 3 months, 6 months, or 1 year. But if we can identify that person, then I think that that would be a tremendous advantage for patients to really take more action in the short run to prevent a catastrophic event. I think depending on the scope and size, I think the NIH would definitely fund something, but I think it would have to be on the order of a $5 or $10 million project and not a $100 million project. I don't see the appetite with the NIH to fund massive trials anymore, because too many of them end up being neutral or non-discoverable, and I think that they feel they can spend their resources and divvy it up more to more people to have more smaller discoveries. Yeah, so I think that it's comparable to what we said in 2010 with the coronary artery disease guidelines that Phil Greenland first authored, but these are obviously a little more prominent and a little more directed. I also think it brings out the power of zero, which is very important. The concept that if you have no atherosclerosis, you don't need to be on statin therapy. Statins are a chemotherapy. They're given, they get into the bloodstream, and they attack something. And I wouldn't give chemotherapy to somebody who doesn't have cancer. I wouldn't give a statin to somebody who doesn't have atherosclerosis. So I think it's very important to recognize that if a person has clean coronaries, their likelihood of benefiting from aspirin, from statins, is going to be almost nil. And the likelihood of harm would go up with bleeding risk and other things. So I think that it's a very important guideline to focus on as far as both no plaque as well as high scores.